Good afternoon, audience, and my pleasure presenting you this topic. Thanks, IPCI. We know SVG is a structurally different than native coronaries. It develops aggressive and faster degeneration by the process of atherosclerosis, which is very, very fast in SVG grafts, and technically challenging subset for intervention associated with more slow flow or no reflow, much more tissue prolapse after an intervention. Long-term patency after intervention is not good, and we must try to improve our outcome by image-guided optimal PCI for this desperate situation of SPG saving. And this is what, when we looked into, I tried to look into a OCT image of a freshly harvested vein graft. I couldn't get it on internet, so I asked my surgical friend to give me a discarded vein graft, and in vivo I've done an OCT of that. If you look, then you can see there is a thick layer of intima, and there is no media. If you see a freshly harvested vein, you don't have any media inside. As time progresses, it is attached to aortic circulation. It undergoes adaptive malformation or adaptation remodeling of the vein, where the intima gets really thickened, which is not a normal intima. That's where we develop faster atherosclerosis. And this is a thin layer of media which is developing because of the smooth muscle cells. So this is what a 3-4 years old vein graft getting arterialized. And the same vein was sent for a histopath. You can see a thin layer of intima with a thin layer of media as compared to an artery. These are from internet. And if you see, there is a thick medial layer in the artery with a thin intima. Here there is a thin intima and a thin media, very thin layer of media. And we don't have any tunica intima or internal elastic lamina, external elastic lamina structurally in a vein. So these are the venous wall. One can clearly see in my specimen. So this is a paper published of 17-18 patients. They have done IVUS versus OCT. And one can see 3 years after CABG, these are asymptomatic patient minded. They have done angiography. If you see these angiography pictures, these are looking absolutely clean as if they're harvested and put recently, 3-year-old, asymptomatic. The IVUS gives very little clue unless until you look at into the OCT pictures. There are different degree of degeneration. One can see a lipid pool here, some degeneration here, sorry, some degeneration here occurring. And no wonder you can think, you can see thin cap here with a necrotic core and all those things. And IVUS fails to identify, not even angiography. And most importantly, this intima is not very normal, so it gets loosened from the medial layer, whatever media is there, and it gets denuded and fresh thrombus attached to the intima. That's where your degeneration process starts. And these are different degree of degeneration with thin cap, some cavitation, there is some fragilities and cracking of the media. But fibrous atheroma or calcifications are very rarely seen in SVG graft. This is one of a case. If you see angiographically, you will think you will put a 12 millimeter stent or 10 millimeter stents, maybe a 3.5. We know we must size these vessels very accurately so that we don't go high pressure on dilatation to prevent slow flow or no reflow. So we took a OCT picture. I'll just skip the runs in interest of time. If you analyze, this is a partially preserved media and a vein structure. There is some degeneration here. So this is relatively okay for stent landing. You can see various degree of degeneration. You can see these cavities forming in the vein graft wall, which is very unique to your vein grafts. And we don't see these cavitations in the artery, native coronary artery. There is a TICFA, you can see thin cap, but with an intact endothelium, you can see the cavitations, and this is a normal landing zone. So appropriately, we thought a 19 millimeter or 20 millimeter stent will be adequate, and we sized this vessel for 3.5 or 4 vessel. So we took a 420 stent and deployed 3.5 into 20 stent at 10 atmosphere. You can prevent no reflow and adequate implantation in a vein graft. and the final result was good. There were minimal tissue prolapse. These are very common in SVG graft, so need not to be chased. You should not do a high pressure or anything. This is a second scenario, absolutely identical vein grafts with very focal degenerative changes with the critical changes. They are SCS patients. So both were imaged. This is patient A. One can see there is a focal degeneration here, and entire length of the vein graft is well preserved. The thickness, look at the thickness of this vein graft in longitudinal view. This is the only area of a focal degeneration. So edge depicted by thrombus formation, cavitation, as I was telling you, is unique to the vein graft, and proximal distal landing zones are very, very good. So we took a 13 millimeter stent and deployed. And coming to case B, identically, there is, you look at the longitudinal view, everywhere in the total length, it is uneven, and there is a thin cap here. So there is no proper landing zone. So you have to be very careful in these patients. So we took a distal diameter was 4.11. It's a relatively healthy zone. This is a necrotic core. There is a cavitation here leading to plaque rupture here, and this was thrombus formation. So we covered all these things. Our landing zones were appropriately selected, and the same patient, looking angiographically identical, we took a 4O stent, and 18 millimeter is the length. So you have to be very, very accurate on these things, and a stent procedure is done. But if you compare both the patient, and you have to give a prediction of failure of vein graft, I'll definitely think this patient B with such a degenerated vein graft all throughout is not going to have a very good long term as compared to patient A. Those angiographically both appear identical or similar. This is another 10 years old SVG graft with ACS. You can see the lot of thrombus inside. There is a previous stent here. So we image the patient, and you can see there is a vein valve seen initially, and there is an area of degeneration here. There is a plaque rupture, and one can see this is a healthy landing zone. Neck TICFA is here. There is a thrombus, and one can see there is a plaque rupture here, and there are cholesterol crystals suggestive of a volcano. And look at this segment. If you see this segment, which is an adequate lumen, in angiography you'll get no clue, and you may think your landing zone, proximal landing zone of the stent could be like this. But if you imagine if you put a stent here, there is a large degenerating cavity inside. You may either dissect that, or if you escape, the long-term result of this stent is not going to be very great. So go a millimeter for OCT gives you that direction. You go 2 millimeter forward to select a proximal zone. So we selected this instead of the previous one, and you can be very appropriate. So we took a 4 into 20 millimeter giant stent, low pressure deployment, slow deployment with pre-treat the patient for vasodilator. None of the patients were done under any distal protection, but there was a haziness at the distal edge of the stent. So we realized something wrong. So we took a OCT image again. One can see there is a dissection at the stent edge, almost medial dissection. Otherwise, the stent was well expanded, so it was covered with a very small stent, focal 4 millimeter into 12 millimeter overlapping stents, and final result was very good. The post pictures were very good. I'll just skip. You expect some amount of plaque prolapse or tissue prolapse invariably in a vein graft, so you need not to optimize those with high pressure to prevent no reflow. We don't have a data to, if you have an adequate lumen, you can escape. This is another 12-year-old degenerated vein graft. You can see something looking very funny here. It's a tributary or a, whatever, it's a plaque rupture or whatever. So it was some ambiguous angiographic finding. Look at the vein graft. Its entire length, it is degenerated totally. And there is every place, if you see, there is a thin cap with a large necrotic core. Those patterns we don't see in native coronaries ever. So if you see all the sections, they were thin cap with large necrotic core. This is a large amount of thrombus. This patient was again treated for an ACS. If you go back, there is the proximal ambiguity was nothing but a plaque rupture. You can see there is a discontinuity intima with a cavity. This was a plaque rupture. So we decided and we treated accordingly with a distal stent 3.5 millimeter into 32 millimeter, and treated adequately with SNP time and again to prevent no reflow, and proximal stent of 20 millimeter, 4 into 20 millimeter stent at very low pressure, because your sizing is good, your landing zone you have selected on the basis of OCT, so you need not to be very aggressive on dilatation, and obviously you are doing a post imaging, so it's always covered, and post OCT the results were absolutely good. There is some tissue prolapse, and we don't chase it. So to conclude my message on SVG graft intervention, intracoronary imaging is crucial for precision PCI in SVG grafts. OCT is clearly better modality than IVUS for imaging of and plan SVG intervention. It guides the operator to identify the most suitable landing zone and proper sizing of the vessel, so that proper stent sizing and landing zone based on OCT can avoid unnecessary pressure post-procedure high pressure balloon dilatation, so that you can minimize the no reflow or slow flow. So thank you very much. This is our PCI imager group. Anybody interested can join us as an admin. We usually request all the members to put their interactive cases, so that it's a group promotes imaging and discussions on the imaging by experts. We have international experts also. Thank you very much.